They used to work very and our diet became richer. People used to eat, they used to grow their food, eat seasonal food grown locally. So now, you see, we have a huge burden of NCD. When I took over, like we were treating the diseases, whether it's cancer, we were treating CKD at the terminal end with dialysis. But then we conduct, when with Aam Aadmi Clinic, then we discovered that if we treat hypertension and diabetes and obesity at the earlier stage, so it can make a difference, it can reduce the disease burden. Otherwise, if you are treating it at the terminal stage, you will not reach anywhere. So that is where Aam Aadmi clinics, and I would even go a step further. That was a concept conceived by Arvind Kejriwal ji and implemented by Bhagwant Mann ji. Yoga, nutritional guidance, yogic exercise, meditation, because you see, whether you talk about heart attack or any other disease or peptic ulcer or migraine and so many other psychosomatic diseases, irritable bowel syndrome, the real cause is stress. The life is very stressful. So stress management, dietary modification, and early diagnosis and treatment. This is the crux of primary health care, and it's in the spirit of Alma-Ata Declaration by the WHO. And today we have represented from the WHO, and very recently their India head, Dr. Roderick H. Offren, he visited us, and he showed keen interest. He was very impressed with the Aam Aadmi clinics and the primary care, the way it's being implemented. And we are working in close collaboration with so many NGOs, and I invite more NGOs to come, and we have done many pilots. Particularly, Ghanshyam ji has already mentioned about STEMI project. So we are working with the private doctors, with the tertiary care institutes, that is Sector 32 Government Medical College, that is Dayanand Medical College. PGI is not a part of STEMI as such. So it's a wonderful, where we trained 700 doctors from PCMS, from the field, from district hospitals, sub-division hospitals, even the community health centers. Now they are trained that it's heart attack, you see, ST wave elevated myocardial infarction is diagnosed in the field. Patient is thrombolized and medicine is provided by the government. And that is another thing. That's another beauty of the model which is being implemented by our worthy Chief Minister. The entire cost is borne by the state government. It is managed and funded by the state government. There is no cost to the patient. So that is where it differs from the Western models, I would say. There the patient has to contribute. Every patient has to contribute. And he has already talked a little bit about vertical integration, that patient, for every Aam Aadmi clinic, there are at least 3 health and wellness centers. We have where we have the trained manpower, and they have about 60 medicines. Then there are about 600 places where yoga, at least 1 lakh people do yoga every day, and 5 lakh people have benefited. Some of them, they start doing it in their homes. So there is a vertical integration that if somebody needs endoscopic surgery or any other routine surgeries, then it is available in the secondary care, again free of cost. All essential drugs, we increased that list from 170 to now 350. All essential drugs are available free of cost to all the patients in the district hospital and the sub-division hospitals. So surgeries are again free for the patients or highly subsidized. CT scan, MRI is possible in all the district hospitals, and CT scan even in some of the sub-division hospitals on the highway. And then we have a network of ambulances. Now the ambulance reaction time is less than 15 minutes. So all these combined together, they has helped. You see, our maternal mortality rate has come down from, it was 105 when we took over, now it's about 92. So we are focusing on everything, starting from schools. The girls should not be anemic. If the girls are not anemic when they leave the college, if the boys are not anemic, so then you see, this is one of the biggest risk factors. So when the lady comes to the hospital, her hemoglobin is 5 or 6 or 7 because she started with 8 or 9. So every school, the teachers are being trained. Every child is being trained in prevention of vector-borne and water-borne diseases as breeding checkers for their own homes. So we have trained ASHA workers, 20,000 ASHA workers as breeding checkers, as caregivers, And even you see how to diagnose early and refer the patient for a stroke, for a heart attack, when to suspect, when to refer. So that is really helping us. So that is where we need the support of NGOs to work at the grassroots level, capacity building. So PDC has done a wonderful work on patient feedback, and that really, you see, gives you, it's like a mirror, feedback, patient feedback system which they have developed, the PDC has developed, and Rag has worked very hard on his team. So it's like a mirror, and we thought that, you see, we were giving all the medicines free, and we gave money to the SMOs, but when they gave us the feedback, only 40% to 60% people were getting the medicines, free medicines from the hospital. But when that mirror was shown to all the healthcare administrators, now it has reached to 70%, 80%, and we want to take it to 95%. So this patient feedback, it's very important. You see, the pregnancy care or Jacha Bacha, it's very important to integrate it into Aam Aadmi clinics, because anemia, hypertension, diabetes, obesity, that is, I mean, you have 9 months to manage that. At least every pregnant lady should have seen the doctor 4 or 5 times, got her BP checked, got her sugar checked. So we are trying to identify high-risk pregnancies. We have the facility in our district hospitals, or we have collaboration with some private hospitals also wherever need be, so that the 100% high-risk pregnancies, they go to a good secondary care hospital, if not a tertiary care hospital. So that is how the health department is working. So a lot of NGOs are helping us, and I would say, if I talk about dialysis, kidney care, I think more than 60% dialysis are being done by the NGOs. That is where the role comes in. And our NHM is giving them money also. We are supporting them. Again, for drug de-addiction, we are supporting. So that this is how it helps. So if somebody is working for kidney patients, so we are giving them 1,700 rupees now per patient. We want excellent care. The Punjab government, my worthy Chief Minister says there is no dearth of money for you, for the health, for education, for employment generation. And you see, we have given already given job letters to 300 plus doctors, MBBS doctors, and we have recruited specialists. We have empaneled a lot of specialists, at least part-time, where there is no gynecologist or anesthetist, because there is a shortage of radiologists and everything. So we have empaneled them, even for our drug-free Punjab. So we are giving 1,500 rupees to the psychiatrist where we need them, where we don't have the psychiatrist per hour. At least the doctor comes for 2 hours. So we are making these services available to them. And with your help, I am sure that we will be able to go further. This is mostly about the vertical integration, starting from yoga, availability, universal availability of drugs in the primary care plus then the secondary care, then tertiary care, up to the liver transplant, organ transplant, STEMI, stroke, now bone marrow transplant. And on the annual, we have a multi-centric trial which is going to start in this month only. Sudden cardiac death. Why sudden cardiac death? What are the cardiac causes? What are the environmental causes? What are the dietary causes? Is it food supplements? Is it something wrong with the indoor air pollution? Is it alpha toxin, steroids, or whatever it is? So then there is a horizontal integration. We have a state task force at the state level, where we have the Department of Health working in tandem with Department of Education, Animal Husbandry, Water Supply Sanitation, local bodies. So we have the working group at the district level, coordination committee, because the fumigation and water testing has to be done by the local bodies or the panchayat or the Department of Water Supply and Sanitation. But if there is a outbreak of any disease, whether it's a diarrheal disease or a fever or dengue or anything, then the health department comes in. But we have gone a step further. We don't wait for the dengue cases. We track the larval index. How many houses we checked? We have trained all our ASHA workers. Now we are training all the teachers in Punjab. We are training all the students to check their own homes. So we track the larval index before the patient gets dengue. So we then our mobile teams from different departments, they go together different homes, and it's a special campaign again started by Arvind Kejriwal ji. I think their campaign was 10 hafte, 10 minute, 10 baje, And our campaign is Har Shukrwar Dengue Pe War. Our people, our directors and our secretary thought that because you see, it's easier to motivate the government people to go and work on a working day rather than on a Sunday. So that way, we could cut down the dengue incidence more than 50% last year. I think this year even we are doing better than that. So similarly for NCDs, so we are able to diagnose now starting from 20% to maybe 75 or 80%, we can diagnose and treat them early, and also motivate them for lifestyle modification. So these are some of the things which we are trying to do. We are trying to follow, you see, the Alma Ata Declaration and Letter and Spirit, which we will be discussing during the day, and I will be talking about that in particular. And I will also be talking about the national and the international priorities. And you see, this, we are working in a very, I would say, hostile international environment, where the resources are being diverted from health, education, from social priority sectors, from agriculture to defense and armamentarian. And under those circumstances, it's a creditive work which is being done by the Bhagwant Mann-led Aam Aadmi Party government. And we are trying to develop models. We are doing so many pilots, which should have a universal appeal, which should, you see, appeal to all of you and to the people, and ultimately the people should be the beneficiary. And last but not the least, I have always believed that as a doctor, even as a politician, I believe that I should talk 20% and listen 80%. I think I am here to listen to you. What I know it. What I'm doing, I'll do that. But I have a lot to learn from you, and we have a lot to learn from each other. And that is how we will progress. If we work together, I am sure together we can do it. Alma Ata Declaration. Thank you very much.
Thank you, sir, for sharing your vision with us. We now move on to the most awaited segment of today's event, the panel discussion on reimagining primary healthcare in India. As India continues its journey towards achieving universal health coverage, it is vital to reflect on innovative models, policy priorities, and ground-level realities that can shape an inclusive and resilient primary healthcare system. This panel brings together some of the most respected voices from government, global institutions, and civil society to share insights and experiences on how we can collectively reimagine primary healthcare for the future. It is my privilege to invite Honorable Health Minister Dr. Balbir Singh Ji, our session chair, to the stage, please. Sir is the Minister of Department of Health and Family Welfare and Department of Medical Education and Research in the Government of Punjab, a retired associate professor and practicing eye surgeon from Patiala. Sir brings together decades of medical expertise with an unwavering commitment to public service. Since assuming office, Sir has been at the forefront of strengthening healthcare infrastructure in the state, ranging from promoting community-based disease prevention to digital health registration systems. With a steadfast belief in evidence-based policy and responsive governance, Sir continues to be a driving force behind transformative health reforms in Punjab. May I now invite Ms. Seema Bansal, our moderator for the session, to the stage, please. Ms. Seema Bansal is the Vice Chairperson of the Punjab Development Commission. She brings over 2 decades of experience in impact consulting, including 23 years at the Boston Consulting Group, where she led Boston Consulting Group's social impact practice across India and Asia Pacific. Now moving on to our panelists. I take pride in inviting Dr. Hatinder Kaur to the stage, please. Dr. Hatinder Kaur is the Director of Health and Family Welfare, Punjab. Ma'am brings a vast experience in public health leadership and currently oversees statewide implementation of all the national health programs. She has been instrumental in expanding Punjab's Aam Aadmi clinics strengthening primary healthcare delivery, and leading capacity building initiatives for the frontline health workers. She combines administrative expertise with a strong commitment to equitable and accessible healthcare. Up next on stage, we would like to have Dr. Vikas Chhabra, please. Dr. Vikas Chhabra is an accomplished surgeon and state president of Indian Medical Association, Punjab. Dr. Chhabra is widely respected for his expertise in general, laparoscopic, endourological, plastic, and laser surgery with over 2 decades of experience in the discipline. May I now invite Dr. Grace Achungura to the stage, please. Dr. Grace is a health economist at the World Health Organization's country office. Based in New Delhi, Dr. Grace plays a leading role in strengthening health systems and advancing strategic health financing across low and middle-income countries. Her data-driven insights and deep expertise in health economics uniquely position her to guide the conversation on sustainable financing as a cornerstone of resilient health systems. Now I would like to invite Dr. Pallavi Kumar to the stage, please. Dr. Pallavi Kumar is the Associate Director of JPIGO, a non-profit organization which works to create transformative healthcare solutions. She is also an Associate Professor of Clinical Medicine at the University of Pennsylvania's Perelman School of Medicine and Section Chief of Oncology Palliative Care at Penn Medicine's Abramson Cancer Care. Now over to Ms. Seema Bansal to lead us through the important and engaging conversation. Thank you.
Thank you so very much. Can I request for you panelists to put up the mics, please, so that... good morning, everyone. Such a pleasure to be here. Before we get started, I wanted to firstly congratulate our Minister, Dr. Balbir, for honestly just his leadership in setting a vision for the Health Department of Punjab and for family and health and family welfare in Punjab, and all of the initiatives which have been taken. I think him, along with the department leadership, has been exceptional in what they have done already so far, but more importantly, what they want to do and what is the desire to make things happen. I also wanted to take a minute to recognize amongst us today we have a lot of people from the field. We have all of the CMOs, I think we have all of the SMOs, we have a number of people from the Aam Aadmi Clinic team, as well as many field functionaries. So can we just have a big round of applause for everyone who's here from the field? Because the fact is that everything that you've heard this morning in terms of what has already happened, all of the achievements which have already been achieved, we will hear a little bit more about that. Without that field force and their engagement every day, this would not have happened. So with that, let me get started. Welcome to all of the panelists. Thank you for being on the stage and thank you for taking up the time. We've heard quite a bit about what has already happened in Punjab. And this session is very much focused on primary healthcare. We're not talking about secondary, we're not talking about tertiary, we're talking about primary healthcare. So we've heard quite a bit about what has already happened. I think what we want to do in this session is talk a little bit about what more can we do. So the session is called Reimagining Primary Healthcare in India and in Punjab. And that's where we're actually going to focus on. We're going to set ourselves a bigger vision, a longer vision, a tougher vision by the end of the session. So with that, if I may get started, Dr. Grace and Dr. Pallavi, maybe you can ground us a little bit in terms of, from all of your years of experience, from everything that you've seen across the country and across the world, if you think about primary healthcare systems, both in India and the world, what is your stretch vision? What is your vision for what a very strong primary healthcare system should look like? What should it actually achieve? And so Dr. Grace, if I can request you to maybe get us started. You've probably seen this across many countries in the world. How would you describe a very well-functioning, high-performance primary healthcare system? And then Dr. Pallavi, I'll come to the same question for you in terms of what is your vision for primary healthcare system for India?
Good morning, everyone. Thank you for the question. And first of all, greetings from the country office in India, and congratulations to the Department of Health for organizing this. With regard to your question, I want us to reflect on reimagining primary health care. From what we have seen as WHO, both in India, Southeast Asia, and across the globe, one of the key things that I would want to emphasize is that reimagining primary health care does not always mean adopting something new. In some cases, it might mean innovative solutions. In other cases, it just might mean strengthening what you already have that works. And for India, we see there are a lot of things that are working very well that we see need to be strengthened. For instance, already India has designed a very robust model of primary health care with the health and wellness centers. In your case, you've also adopted the Aam clinics with the primary health teams, multidisciplinary teams in some cases. We've also seen reskilling some of the health workforce in order to make them fit for purpose, competency-based. We are seeing more public financing being pushed into primary health care, which is one of the key cornerstones we have seen globally for high-performing primary health care systems. We are seeing this at union level. We are seeing this at state levels. Every state is trying to put in a little bit more funding. We are seeing adoption of digital health tools, use of telehealth medicine. So what does it mean now for India going forward? One, the sustainment of political will. I'll give a cautionary tale of Mexico. I don't know how many of you are aware of Seguro Popular. It was a very big publicly subsidized program that was supporting both primary health care and secondary care in Mexico that was driving a lot of public health gains, both from the primary health care level for that country. When a new government came in, it was completely dismantled and had to build up again. And the process of building back has meant that they have lost some of the public health gains. And so that's why we emphasize that you don't always have to build something new. Sustaining the political will and the reason for it is important. The second thing that we are seeing, and that India has done a lot in showing the way for, in many cases, is public-private partnership, engaging the private sector. India has done that very beautifully and is well quoted all over the world with the TB program. And the mission director for NHM was talking about non-communicable diseases as a major problem for Punjab, but we see that across the pan-India. One of the ways that some countries, for instance, Thailand has done this, is how to innovatively contract private sectors, primary care providers, to extend service coverage, particularly for those areas where the public is not able to extend service coverage adequately. How they are using strategic contracts to engage the private sector, small primary care providers to provide screening services, incentivizing screening and other preventive measures. And they've done this very well in Bangkok, where the public sector is very limited. And so that is something that can be explored, not just in Punjab, but all over India. The other thing for India that I think building on some of the gains, the e-governance gains that the government has done, we have Aadhaar, we have ABDM, we have IHIP, how that can be used now to ensure vertical integration of the services. We have a strong, fairly strong primary care service. We have now the health insurance schemes that are providing secondary and tertiary care for the populace. But how do we ensure effective follow-up, both forward and backward referral? And there, the leveraging the digital health tools is very, very critical. Not only that, innovative financing mechanisms. Some countries like Estonia, again Thailand and others that we are seeing are using mechanisms, France as well, to pair up secondary care like district hospitals and the primary health care networks to coordinate care across those and incentivizing them to have that kind of coordination. I don't know how much time I have. There's a lot more I can say. Yes.
Change the mics. Okay. Thank you, Dr. Grace. You mentioned three things. You mentioned political will is very critical to make sure that changes actually happen, transformation happens. You talked about public-private partnerships and thinking about how private sector can be brought in. And you also talked about digital systems and how we can actually use digital systems, e-governance systems, to make sure that we actually have linkages. We'll want to come to Dr. Pallavi. And Dr. Pallavi, if you can talk a little bit more about, these are very systems, governance kind of topics that Dr. Grace talked about. I think from a point of view of health outcomes and disease verticals, if you can bring us a little bit about to that space, what should the primary healthcare system actually try and achieve or try and focus on?
Yeah. Thank you, Dr. Bansal, and thank you for giving me this opportunity. Thank you to the government of Punjab and PDC. I will try to bring a more of a community perspective to it and also my learning from the India primary healthcare context, because as in Japaigo, we have been supporting the comprehensive primary healthcare right from 2018 when it all started evolving. And as you rightly said that one is a way of looking at a more of a system perspective, but also the disease and the community. So I think the way the comprehensive primary healthcare has progressed, that lot of things has achieved, we have achieved, but I think it's high time that we should be looking at more from an integrated approach. We have still been looking at comprehensive primary healthcare more of a silo approach, looking from a disease perspective. We are not looking at the life cycle approach. So for example, if one patient is coming, why can't we provide that integrated screening rather than calling same person and again from different disease? So that is one of the learning and the way the government of India is also looking at. And recently MD sir mentioned about the NHM workshop forward. So a lot of focus was also how to build the comprehensive primary healthcare more forward looking. And when it's come to looking forward, it needs to have more resilient. And as we know, and we have also learned our lesson from the COVID-19. So how we are going to ensure that the lesson which is learned, how to make the primary healthcare more epidemic and the climate resilient, because as we are moving, a lot of the disease patterns are changing. If you look at the climate and the disease condition, more and more vector-borne diseases are happening. So how we can also empower, apart from the disease thing, how we also empower to make the primary healthcare more resilient, how to make them more in terms of connecting with the community, detecting the disease, treating it, and also making community as an important key stakeholder. So that is one of the things. Coming to the climate, because we all know that the climate, the heat, air pollution is there, the heat waves is there, and also a lot of other climatic things. So how to look from a lens where we want that the services are resilient. It should not be stopped based on one shocks come, to how to also translate those into making a more resilient. And one thing we need to invest on the skilling of the primary healthcare team. More and more skilling need to be done, not in terms of just looking at the services, but also the competency. How competent the team is, and looking at the value proposition that each team members bring. Just adding one person more to the primary health care is not going to solve it. What is the unique value proposition that each team member are bringing to the table is something we should be looking at. And also the governance and the accountability, because when we say the primary health care, one of the biggest institution we just talked about, but actually we are not doing much on, is the community institution. Community can't be seen as a person specific, it's more about the institution. So how you're going to bring that accountability and also make the community be be not as a recipient, but also the decision maker into that. So these are 4-5 learning what I will say that we can take it from the ongoing activity and make primary healthcare more resilient and focused.
Yeah, thank you so very much. Lots of food for thought, agility, community-based, governance systems, integration, forward, backward linkages, many things, and climate, many things to think about. Let me come to you, Dr. Hitinder. You've been in the field. I think you were a CMO when the whole Aam Aadmi Clinic initiative started. And for the last year, you've looked at this and led this from the center, I would say, at the state level. In your view, as a doctor, as a medical professional, what has really already been achieved? And what do you think are the ways to go when we look at primary healthcare in Punjab?
Thank you, Madam Seema Bansal ji, for the question. Good morning, everyone. First of all, I was Civil Surgeon Ludhiana when the first Aam Aadmi Clinic in Punjab was inaugurated by our Honorable Chief Minister, sir. So I have seen it evolve as an idea and of primary health care, and now it is a very solid and effective and very critical component of our primary healthcare delivery systems. There have been many upsides. The main, as MD sir has also mentioned, has been that accessibility, the easy accessibility. Now the citizens, they have a very qualified MBBS doctor. Medicines, as sir has mentioned, 107 basic medicines. Then diagnostic tests, which include all the routine tests which are needed in primary healthcare, including dengue, typhoid, HIV, hepatitis B, C, and HbA1c, a lot of tests. They are done free. They are done in PPP mode. So it leads the out-of-pocket expenditure has considerably reduced. So apart from this accessibility, this has also decentralized our patient footfall. Now our footfall in our already burdened subdivisional hospitals and district hospitals and medical colleges, it has decentralized that primary health care to our Aam Aadmi clinics. So as sir has already said, almost 3.7 crore patients and 1.7 crore unique visits. And again, 1.3 crore diagnostic tests, they have already been conducted here. So this has been a major upside. Now our secondary and tertiary level health institutions, they can concentrate more on secondary and tertiary health care. And another upside has been, as sir has mentioned, that the digital monitoring, the surveillance, the real-time surveillance that we have of our staff in Aam Aadmi Clinic. And this has reduced a lot of absenteeism. As our Aam Aadmi clinics, they are situated in slums, in peri-urban areas, in remote border areas. So there was a lot of absenteeism. Now we have a real-time surveillance on a dashboard, and that has been a big upside. Yes, more, one thing is the training and the skill building part. First of all, I would like to congratulate all the civil surgeons, all the district officers, all the SMOs who have been working really hard for the success of this Aam Aadmi Clinic model. Thank you so much. And our administrators, our Honorable Health Minister, sir, who is very, very persuasive and always interacts with all of you. So thank you, everybody. One thing is that our MBBS medical officers who man these Aam Aadmi clinics, they are fresh graduates, MBBS students. So we are trying to train them regarding protocol-based treatments, some SOPs, some treatment algorithms, which are very standard for the common practices. So that training is going on. And also recruitment and retention, that we have decentralized it. And of course, the integration of primary health care into our Aam Aadmi clinics. we are taking steps for that. So it has to transform from curative to preventive and promotive health as well. Thank you.
Thank you so much. Sorry for the mic system. Sir, coming to you, last but not the least, I think you have the privilege of looking at the system a little bit from the inside and a little bit from the outside. As the head of state president of Indian Medical Association, you have probably a very bird's eye view of what has been happening in primary healthcare in Punjab from a government perspective. So I think it'll be very interesting for us to hear your perspective. You know, so there's an outside-in perspective because you're not necessarily a part of the system, but you see it very closely on a day-to-day basis. So from your point of view, again as a medical professional, and with the idea of every person in Punjab should have access to free, high-quality primary health care, we should focus on preventive and early-stage curative if those are the goals. What do you think has been the positive impacts of whatever we've done? And what more do you believe we need to do as you see the system?
Thank you, Ms. Seema. And good morning, everybody. Good morning, sir. Earlier, when in Delhi, Aam Aadmi Clinic concept was launched, everyone thought that this is a political gimmick only. But when we see here in Punjab, it has revolutionized the primary healthcare system in Punjab. The main the best part is that the patient, as Ghanshyam Thori sir has said, the patient is getting access to the medical facility very near to his home, maybe in 2 or 3 kilometers, which from our perspectives, we though were having so many acts and so many things to curb the menace of quackery, we were not able to do that. But this is like imposing a sanctions on the quackery. So it will lead to more treatment by the more qualified people, not less than the MBBS. As the patient will be having all the MBBS doctors in his or her vicinity, so he or she will not have to go to the quacks, which was earlier their compulsion. This is the biggest thing which we think. Earlier, we have been talking with Thori sir, antimicrobial resistance in the context of antimicrobial resistance. At the village level, antimicrobial drugs are used just like candies. Thoda sa जुखाम हुआ, they'll give antimicrobial drugs. Thoda sa khansi हुआ, they'll give antimicrobial drugs. But ma'am from WHO will agree to me that in US and UK, or in European countries, antimicrobial drugs are not being given so frequently, which we are giving here. So this will also prevent development of resistance of antimicrobial drugs, which is a very big thing. And now when we come to non-communicable diseases, hypertension, diabetes are the two deadliest non-communicable diseases which are very prevalent in Punjab. And because of this, we are losing so many people in the younger age, and because of stroke and because of gangrene, because of diabetes, we are actually losing manpower. So with this, I think we'll be able to save so many hearts, we will be able to save so many brains, and we will be able to save so many kidneys. Thank you.
Thank you so much, sir. I think the 2 or 3 themes which are coming to me in terms of where do we go from here. I think a lot has been done. The base has been well established. We have access. We have 881 clinics, more to come. We have staff which comes in every day, you know, because of the governance systems, the digital systems, the incentive systems. We have a surety of drugs. So all of the baseline is now actually set. The 2 or 3 things that I am hearing from the previous sort of, addresses in the morning, as well as from all of you, what we need to focus on is, right now, what is happening is still largely curative. Today, potentially, is the first set of preventive applications that in some ways that we're launching with maternal mortality, NCDs, etc. So what I'm hearing is more preventive. How can we integrate more preventive? Secondly, as we integrate more preventive, how do we ensure referrals, upwards and backwards linkages? And thirdly, how do we actually do a lot more around community and outreach and, starting from there. So if those are the 2 or 3 themes, let me come back and say that, Grace, Pallavi, if you had to say, these are the 3 initiatives from whatever you understand of Punjab and Punjab's primary healthcare. If you had to give us 3 very specific initiatives to focus on, whether it be disease verticals that we focus on, whether it be digital systems that we focus on, or anything else, skill systems that we focus on, what would be your advice on 3 things that government of Punjab must do going forward based on what we've already built? And I'll ask the same questions to all of you. Either of you, Dr. Pallavi, if you want to start, or Dr. Grace, if you want to start.
Okay. Thank you. And I agree with the summary that you have said in terms of what's coming through. I would just emphasize 2 things. One, data systems. You cannot run away from data systems in terms of monitoring, not just performance in terms of the outcomes, but also the quality of care around NCDs, maternal child health, and also, as she had talked about, some of those diseases that are emerging because of climate, new pathogens, and the like. So these information systems coming through from the community level. One of the things that was mentioned earlier was around the community health workers, the extension of that force in terms of bridging the formal system and the community level. In some countries, we are seeing now digital health literacy volunteers who are helping and would further the work of this, for instance, WhatsApp platform that is being launched here, in helping the local citizens, particularly in the remote areas, to engage better with the digital tools. That will further match the work around telemedicine, some of these mobile health apps that are increasing access to prevention messages and all. So that is one. 2, I would say incentivizing the workforce to around prevention. One of the things we see is that if you are incentivizing me through the amount of money you pay me or how you pay me to focus a lot on immunization versus, say, malaria, that's where, as a health worker, my attention will go. Because even though we have our code of ethics as a health workers, our behaviors are also driven by how they are incentivized. So building an incentive system that drives attention towards these priorities that have been mentioned, NCDs, as well as prevention priorities. How do you make sure that a secondary care private hospital, for instance, that is more interested in admitting a patient, now is more responsive to, hey, I want you to focus a lot more on your prevention. How do you design the payment or contracting mechanism for such a facility to want to have more healthier patients than sicker patients? So those are some of the 2 things that I would guide on the government to focus on.
Thank you. Very interesting, Dr. Pallavi. I'm just making a list of everything that you all are saying. And
So just to add, I think based on what Punjab has achieved so far, I think one thing that need to be more strengthened in terms of the linkages of the primary health care with the secondary and tertiary. And I think the government of India has, and even the Punjab has done a lot on the teleconsultation piece. So how this teleconsultation can be strengthened, and also the clinical decision support system can be integrated, because we can't be transferring every thing on the secondary or the tertiary. We have to see also how we are going to decongestion the secondary and tertiary, but also add the value to the primary health care. So that is one of the piece. In terms of the integration of program, I'm coming back to the integration, because in the morning I heard sir also mention about the TV program. So how we are also looking at the integration of TV with the maternal health, TV with the NCD. So those kind of the integration also need to be done. And I would also like to focus on one thing, which is the mental health. Although we have been not talking much about the mental health, so when we are looking at the integration of the vertical program, how to have that mental health integrated into the larger ambit of the primary health care. So that's not like something which is option for us, but that is a necessity for us as we move forward. And the third is the digital. Although we have been working a lot on the digital, but how to also use the digital for mapping the migrant population or the displaced population. One example, yesterday when I was coming from Chandigarh airport to the Chandigarh city, there was some population I was not able to make out, is this the Punjab population or the migrant population? And I think it's also important to how to track, because now they are the part of the system itself. So how to have the digital nuances to track those population and make them a part of the primary health care. So these three things which come top on my mind.
Thank you. We're building a good list. Dr. Vikas, would you like to add to the list? And then I'll ask Dr. Hindal to comment on the purpose. Dr. Vikas, pehle aap. We'll come to that.
As far as primary, secondary and tertiary healthcare system is concerned, what I feel, the primary health system with this Aam Aadmi clinic in coming 1 year or so will be perfect in India. As far as we consider India, it will be just like a perfect. And tertiary, as we consider tertiary healthcare center, we are already having 14 medical colleges and some very big hospitals, corporate hospitals in Punjab. So the problem of primary and tertiary healthcare system will be okay. It will not be a burden to Punjab. It is the secondary healthcare system which is more important, which the person needs more. And for that, there is a very good scheme, Mukhyamantri, आयुष्मान भारत के मुख्यमंत्री सेहत बीमा योजना, जो कि हमारे मुख्यमंत्री साहब ने उसका जो बजट भी बढ़ाया है, and the capping has been increased from 5 lakh to 10 lakh. So this is a very good scheme, and if we go and we implement this scheme in spirit, and the small pitfalls of the schemes, if we can take out those small pitfalls, and if the payments can be regularized, it can be a wonderful scheme, because we can use already existing private hospitals just like government hospitals, because they are working on the role of government base, almost on the role of government. So we don't need to expand secondary healthcare system. Secondary healthcare system is already, though that is in private, but when we implement this scheme in spirit, it will be just like a government secondary health system.
Got it. Thank you so very much. I'm going to come to the audience in a minute. The key question to the audience is, if you could suggest one initiative that we must integrate in our primary healthcare system in Punjab, what would that be? That is open to everyone. But before I come to that, and as all of you think about it, and if someone can organize audience mics, Dr. Hitinder, you've heard a long set of things. Sir, आप कुछ कहना चाहते हैं? हाँ जी.
Just responding to my fellow panelist. First of all, our worthy Chief Secretary, Mr. K.E.P. Sinha is here. Let's welcome him with a loud cheers. Thank you. Ma'am, as far as the political will is concerned, I think it's there. It's manifest from what we are doing, you have heard. And Dr. Shavda has briefly talked about the new initiative which we are going to launch very soon. That's about the universal health coverage, where every family in Punjab will have a coverage of 1 million rupees, any family, and they can go any government hospital or the empaneled hospitals and be treated for all the diseases, and managed and funded by the Punjab government, where the patient doesn't have to, they don't have, the poor people don't have to contribute. Just to, I would say, authenticate what Dr. Palvi has said. You see, the dengue used to be a seasonal problem. It used to start in June, July, and it will be over by the November. But now we have, throughout the year, the dengue is there. The vector has outsmarted us. And another thing, you see, I think it's a national experience. We were giving anti-tubercular drugs and patients were not responding. Then we added diet. We started giving them nutrition, and the response was better. And third thing, I think you were talking about the air pollution. I think that's a very critical component. Not only for tuberculosis, I would say we are seeing more of. You see, the smokers used to have lung cancer. Now, a lot of non-smokers are going to have, I will come to the solutions also. Like we had the alcoholic liver disease. Now we have the non-alcoholic liver disease. That's again a lifestyle disorder. So I think the way to go about is that we have to find cost-effective solutions with the help of so many NGOs, so many think tanks. I mean, they are here, and I'm looking forward to their views on this. I think in addition to early diagnosis and treatment, we have to focus on prevention. Again, you see air, the food you eat, the chemical-laden foods, the chemicals we use in agriculture, that is the message of the WHO also from Alberta Declaration. So we have to have food which is healthy, we have to have air which is healthy, and we have to have water which is healthy. So health is not only about medicine or the curative services, and that is where our focus is. That's where is, and in addition to this WhatsApp initiative, you see it's a game changer. Now, unlike in the Western models, if the patient has any problem, he can go to his own Aam Aadmi clinic. Suppose he is visiting somebody and he has a recurrence, then the record is there on his mobile, and he can go and tell the doctor that this is the problem I am suffering from. I am diabetic and hypertension. These are my reports. So I think it's a game changer, and we need to do more of it in secondary care and tertiary.
100%, sir. Like you said, and I think like Dr. Grace said, once you have digital systems, once you have the pipeline set up, then you can push anything through that pipeline. Once you actually have a baseline, then you can actually continue to build on that baseline. And I think what you've done in Punjab with your leadership, and we've been very happy to support that, is create those basic pipelines and highways. Now we can actually push whatever we want on top of that. Patients are connected, clinics are connected, every patient is digitally tracked at this point of time. We know exactly where they came. We can now, I think, track if they came to clinic A in month 1 and then they went to Aam Aadmi clinic in another clinic B in month 2, we know. So what you're talking about, migration, while we may not be able to track migration interstate right now, we are able to track migration intrastate. We know exactly where a patient went, etc. Right? Dr. Hartinder, any sort of comments from you, especially in terms of this whole idea of preventive data integration? When you were in the field, you would have also looked at the health and wellness centers. We have a very large footprint. Any thoughts which come from all of that in terms of how we can strengthen preventive through data and through health and wellness centers and their role in Aam Aadmi clinics?
Actually, now that we have done very well on the curative side, so I feel that Aam Aadmi clinics also need to function as wellness clinics. So as sir always says, maybe we will start with wellness sessions and CM Ki Yog Shala and counseling in the Aam Aadmi clinics in the near future. But yes, definitely we'll have to overcome certain challenges. For integrating primary healthcare into the Aam Aadmi clinics, many of our Aam Aadmi clinics, they have a very high footfall. Maybe more than 150 patients per day they are examining. So we are trying to overcome that. We are thinking of starting an evening OPD in the same Aam Aadmi clinic with the same infrastructure. And also we are trying to have more Aam Aadmi clinics in the vicinity. So if we have to start primary health care in Aam Aadmi clinics, in present Aam Aadmi clinics, as Dr. Grace has also said, we will have to incentivize, and we will definitely do something. And we have a very good workforce in Aam Aadmi clinics. And data integration, yes, that is definitely important because it is very important for policy making as well. So as MD NHM sir has also said, we now have on a click, we have the dashboard where we can monitor the data, and I think it will lead to a more robust healthcare system.
Thank you. Do we have time for audience inputs? Anurag, do we have time for audience inputs? Okay, great. Okay, so my question was, you've heard quite a bit about what's happened in Punjab with Aam Aadmi clinics, with primary healthcare. I think there's a great understanding of what do we already have. So my question is, if you had one idea, one specific thought in terms of what is the next set of things that we should build in Punjab to reimagine primary healthcare, what would that idea be? So if you can raise your hand, and if I can request some of the people who are in the...
There
who
are a
are
few
sup-
of us who have the handheld mics. Please come forward and hand it to the candidates who want to talk.
there's a gentleman over there in the red shirt. If someone can please hand the
Kindly,
mic.
please, who has, kindly get the handheld mics.
Sir, I just request everyone to keep it brief so that we can give a chance to a lot of people.
Myself, Dr. Chandrasekhar, Civil Surgeon, Fitco. My point is, we are doing very well on the Aam Aadmi Clinic on curative part, but our preventive and promotive part needs to be strengthened. For this, we need the integration of our health and wellness center with the Aam Aadmi clinics. For supervision, we need to, our medical officers in the Aam Aadmi clinics should be linked with our HWCs.
Thank you, sir. Fair point. I think something that I also very strongly believe in. There's a gentleman over there.
Thank you. Congratulations to the government of Punjab because we have addressed the issues of accessibility and affordability through the Aam Aadmi Clinic. Just one suggestion regarding focusing on the primary healthcare in urban areas. So when we are talking about urban areas, it is very difficult for a person who is invisible or the last mile to be looked into. So my request is that our decentralized model and especially the involvement of the urban local bodies should be, when they are responsible for all the facilities in the city, they should also be accountable for the systems. So that, especially in the bigger cities, when we are talking about Ludhiana, Jalandhar and Amritsar, urban local bodies should be involved. This is one thing. And secondly, when we are talking about the last mile delivery, it is the person who is not able to prove on paper that he or she exists when we are talking about the migration. So these populations should need be the targeted approach when we are doing anything related to the primary health. Thank you, sir.
Yeah, good afternoon. I have a small suggestion. If we can add EPI immunization, so that will go a long way in giving services. Thank you.
Good morning. Thank you so much for this enlightening debate and so much knowledge that has been imparted. Because of the so much accessibility and so much acceptance of the Aam Aadmi clinics, I would like to add that we would need to add this mental health screening in through the Aam Aadmi clinics, because we have been doing a pilot project in the district Mohali through PGI that is basically doing the screening of Aam Aadmi, this mental health illnesses. So that way, these can be done in the Aam Aadmi clinics along with the availability of couple of these medicines related to the common mental illnesses. Thank you.
Very good informative session. So Dr. Chavda has taken a very good observation regarding the reduction of the quackery in the field after the launch of this arm clinic. So my just simple query is, is there any plan we can have for the district level with IMA integration with the arm clinics, so that they can get boosted and more quackery will be done with the integration of the IMA meetings and all in the field?
Thanks for the question. IMA has launched a program for the younger graduates, where they can approach IMA through a portal for getting themselves employed. So we can integrate that portal with the health system of Punjab. So it will be easier for both the new graduates and for the government also to recruit those doctors.
So, this side. Okay. Dr. Nora Health, we run the Care Companion program in Punjab. Highly skilled healthcare workers spend a lot of time in administrative tasks. How can we minimize that? And one suggestion is do we have the courage to go away with all
जी
digitalization away from paper records that will itself save health worker time. My second suggestion is how to empower family caregiver holistically so that it is at full. My second suggestion is how to empower the family caregiver so that all the programs that we are talking about is a pull from the family and the behavior change happens even more effectively at the family caregiver.
Can you maybe elaborate on that for, I don't think everyone understands exactly what you mean, so.
Okay. The first suggestion was more systematic to go away from paper-based records in order to save the time of the healthcare worker. The second comes from the intervention that we do, which is the Care Companion program, where we empower family caregivers with the information that they need at the critical time in order for behavior change to happen. And we do it across condition areas, and we do it across health, different levels of health system, and we've seen we have an automatic timer.
We can hear you. Go ahead. Please complete.
Yeah.
Something
is wrong. I think you have to move a little bit this side or that side.
We can hear you.
So I will explain it. The first and most important thing is that we agree with you. We have done it in education. We are doing it in health. These doctors, they need not to be burdened about whether the washrooms are clean or you see if the generator is working, because there are many problems related to that, or the oxygen plant is working. So we are going to have facility manager. We are starting with the district hospitals. So doctors will be freed from that responsibility, and there will be a person who will be responsible for all kind of availability of drugs and so many other things. Electric supply and the systems are working, the equipment is working. So this is for the first time we are doing it. We are introducing it, facility manager. Digitization, our primary healthcare model is 100% digitized with real-time feedback. Now this WhatsApp, I think there is a problem in secondary care and tertiary care, and it's a challenge for our SMOs, and because you see our senior doctors, they are reluctant for this. And I think another challenge which remains is that anybody and everybody working in Aam Aadmi Clinic should be a family physician. He should know something about everything, about pregnancy care, about newborn care, about geriatric care, general medicine, most of the common diseases, eye diseases, ENT diseases. That is not the case now anywhere in India. I think we are focusing on that. Every graduate passing out will have to have advanced life support training. Any graduate should be desirably have a basic life support, but all medical graduate, whether doctors or nurses, that's a challenge. That is where we need capacity building and resource building. So we are going in for digitization at primary care, secondary care, tertiary care, but there are these teething troubles in secondary care and tertiary care. We want to integrate it. It really helps. It has revolutionized primary care. It will revolutionize other cares also. So over to our civil surgeons and SMOs to add digitization, and we are having these hospital engineers and everything now, so that the doctor should only be taking care of patients.
Any other audience inputs?
Sir,
I think we have. Go ahead.
So yeah, so it's a very good model for the primary healthcare. So I have one quick information from your side. One is how to actively engage the community participation to make it a more patient primary healthcare friendly. And second is the involvement is of the mental health care component is not just limited to the substance abuse, but the other concerns which arises after the COVID as a primary healthcare component. And third is how the technology will further imaginate, or we say the reimagination of the primary healthcare to make it more resilient and people-centering, which is WhatsApp is one of the component to just sending the messages, but the other components like the primary healthcare from the preventive perspective, not just a curative perspective.
Thank you. I think there were a few comments in the back. We'll take one or two more. Sorry, who has the mic? There's two comments in the back over there. People have their hands raised. Go ahead, ma'am.
Congratulations, Honorable Sir, for the Aam Aadmi clinics and prevention care. So just a suggestion, I think even dental care can be added some places. Thank you.
We'll take the last couple of comments, those two in the back, and then we'll come back to wrap up.
Sir, on our health minister and health department is doing great job. Sir, one little suggestion. Our health department is very good job in anti-rabies vaccination, and we are seeing that every day the dog bite cases are increasing. So suggestion for the other department or local bodies that the one program is there, ABC, Animal Birth Control. That can be strengthened, sir, so that the number of dogs can be, in the coming time, can be decreased, so we can manage efficiently the anti-rabies and this campaign, sir. Thank you, sir.
I think that's the last comment that we'll take, then we'll come back to the stage.
Congratulations to Honorable Health Minister and Government of Punjab, especially for rolling out NCD program at the Aam Aadmi Clinic. My small suggestion is that we have trained our medical officers with SOPs for diabetes, but a huge chunk of pre-diabetics are going into diabetes. And especially concerning South Asians, we know from studies that South Asians have a huge predilection for transformation from pre-diabetes to diabetes. I mean, it is that seismogenic effect is almost 9/10 of people we are not detecting. So one suggestion would be, because a lot of diabetic associations have come up with even pharmaceutical measures, but aside from pharmaceutical measures, we can use counseling, lifestyle counseling, those programs at the Aam Aadmi Clinic, diet counseling, lifestyle measures, and even drugs like metformin. I mean, there's a lot of huge evidence-based medicine is there that if we use metformin in patients who have an A1C between 5.7 to 6.4, we can prevent the progression of pre-diabetes to diabetes. And India being the diabetic capital of the world, I think this would be a huge game changer. And we should act fast, because it's not like that we bolt the stable once the horse is bolted out. So that is one thing I think that can be looked into.
Thank you very much. We started the session with saying that we want to reimagine primary healthcare in India and in Punjab. I think I've got a list of about 20 different ideas from all of you in terms of what are the things that we can actually do in Punjab. I won't even attempt to list all of them, but some of the big things which came up were strengthening our data systems and digital systems and technology, taking it closer to our patients, building on what is there already, including WhatsApp, and how do we help patients, families, and our system use technology more and more to deliver. Second, incentive systems for preventive care. Right now, maybe our incentive systems are for whoever walks in, there's an incentive for treating patients. Can we actually think about incentive systems for our staff to go further on prevention? Linkage of primary, secondary, tertiary, clinical decision support systems for our staff so that they have very high quality systems that can help them understand what to do when a patient walks in. Integration of very specific Government of India programs, NHM programs. Mental health came up in a very big way. Secondary healthcare and integrating of private secondary healthcare into what we are doing within the government system through insurance. Many other ideas, ULBs and how can we look at ULBs, dental care, looking at rabies a bit more, pre-diabetes, family care, and looking at who is providing family care within the family and can we actually strengthen them and train them. And so many other things. Like I said, I will not aim to list them. So I think, look, you've given us all a lot of food for thought in terms of where we can take this. over the next 6 months, 1 year, 2 years. I would request if anyone on the stage has any closing comments to make, quick closing comments, any reflections, and then finally I would request Dr. Balbir to close the session. But to each of our 4 panelists, any closing comments that you would like to make?
Thank you once again to congratulate the state of Punjab for what you are doing. This is one of the case studies that we shall be sharing as WHO across the world. But to say that at the center of the supply side or the provision side is a human being. And so our actions in reimagining primary care must focus on that human being, the healthcare worker, not just in the skills they need and how we need them to behave, but also their occupational safety and what makes them sustainable aspects of the provision. So also how we reskill them based on competency-based frameworks to make them fit for purpose. If we are reimagining a new primary healthcare delivery system, how do we make them fit for purpose in terms of the pre-service training and the in-service training? Thank you.
Just one last point to make. I think there is a lot to learn when it comes to the preventive care. I think a lot of states are being very innovative. So here we are talking about the yoga, the northeastern states are talking about the Zumba and other things. So how to look from also, who are the audience we are catering it? So one thing can't fit for everything, so you have to also customize. Another piece, the learning can be also looking at the Ayush linkages. In India, Ayush has done a lot of commendable jobs. So also how to see the primary healthcare have a linkages with the Ayush facility. That's 2 points is coming on my mind. Thank you.
I think when something good has to happen, then a lot of good people, they come together, and that has happened today. And now we have to stay together and work together, and I'm sure that we can change many things, many things. And last but not the least, there are a lot of, I think, doctors from even Aam Aadmi clinics and civil surgeons and SMOs. You can have your own innovations. You see, give your proposal, we will give you funding. So maybe adapt to the local needs of the people. And just to give you one example, that media did a good job, that they brought it to my notice, that there are 7 rivers which are cut off from the mainland Punjab across the Ravi, and there are 8 pregnant ladies. So that way I intervened immediately, and we arranged a boat ambulance kind of thing for them in collaboration with the military. They were brought to the district hospital, and 2 of them, I think 3 of them, they have delivered very healthy babies, and rest we are taking care of. So similarly, you see, if somebody is sitting in Gurdaspur, I don't know what is happening there. So I think the 28 doctors, we are sending them for training. They went to IIM Ahmedabad. So I think they have also started, and recently we sent some doctors to AIIMS, National Drug Dependence and Treatment Center. So they have come up with very brilliant ideas. So all of you take one new initiative which you have not done so far. Be it child care, that every child you check his hemoglobin, height, weight, and you see what can you do to bring down the rate of, I would say, stunting and wasting. In mother care, you can have your own models. It's something really creditable that our Director of Family Welfare and Deputy Commissioner and Civil Surgeon in Firozpur, they work together. The maternal mortality was 400 plus. Now I think it's less than 100. So they took some local initiatives. So I request you to take local initiative at SMO level, at medical, at all levels. Do something new, think of something and do something, and then you come up with ideas. If you have a good ideas, we will implement it at the state level, and maybe you never know, you become a global leader in that. You see, that is how ORS was made popular by a simple doctor in Bangladesh.
I think in the last I would like to say that we are on the right track. And when I see HM sir himself noting down all the suggestions, I feel that we are in the safe hands. He being doctor, we are in safe hands. Thank you.
Sir, I would like to assure you on behalf of the entire directorate, as well as all my civil surgeons, district program officers and SMOs on their behalf, that we will definitely work hard and not only for reimagining and transforming primary healthcare, but secondary and tertiary healthcare as well.
Thank you so very much. I just want to say that, look, this is not the ending of a conversation. I think today what happened on this stage and what is happening today is the beginning of a conversation. I will make a commitment, if I'm allowed, sir, on the behalf of the Department of Health and Family Welfare, but also Punjab Development Commission, that anyone who is in this room, if they have an idea, if they have a suggestion on what we need to do and what we should do, our doors are always open. You can reach out to us, whether it is someone from the state, whether it's a civil surgeon, SMO, whether it is someone from outside, whether Dr. Grace, it's you, Dr. Pallavi, it's you, Dr. Vikas, it's you. We are very happy to, this is a journey. And what we've described is only the starting point of a journey. And this journey will continue. We want to make primary healthcare systems and the overall healthcare system one of the best in Punjab. We want to learn from other states, and we want to get to a point where other states can also learn from us. So this is a commitment that anyone who has an idea, anyone who has a suggestion, anyone who has an input, we would love to continue to take this conversation forward. I also want to thank everyone on stage here. Dr. Grace, Dr. Pallavi, you've traveled long ways on a Sunday to come here and to be with us. Dr. Vikas, thank you for joining us. Dr. Hinder, thank you for your leadership in doing everything that you're doing on an everyday basis. And Dr. Balbir, I am in awe of you. I am generally in awe of you. I think very few states can boast of having a health minister who's firstly a qualified doctor to begin with. But then also someone who's just out in the field every day and looking at what is happening, thinking about what more can be done. We at PDC, we joke that Dr. Balbir has more ideas than we can actually implement. So we need to find a way to help Dr. Balbir maybe ideate less, because there are just so many things that you want to do, and your leadership has been awe-inspiring. So with that, thank you very much. We will move on to the next session in a bit. We will be told what that is, but if I can request the group, we would love to get a picture with all of you. Thank you so very much.
Well, that was a very rich, thought-provoking and interactive session with active participation from the audience as well. I would like to thank our camera. Okay, we want a picture? Yes, sure, there is a camera out there. May I request for a picture, please? While memorable pictures are being taken, I would take the opportunity to thank Honorable Health Minister, sir, and all the esteemed panelists for being here with us today for this rich and thought-provoking discussion, for taking time out for us today, and also the audience for patiently listening and actively participating in the session. Thank you all. Please keep seated for, as we will move on to the next segment of the event. The power will be switched off for a brief moment now, as the supply has to be shifted from one segment to another. Kindly bear with it. Thank you.